welcome to those of you online as well as the group in person. And on behalf of TIER, I would like to thank Dr. Aaron Orkin, for being our speaker today. Before we get started with the talk, I want to begin by acknowledging that we're on the traditional territory of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And we recently marked Truth and Reconciliation Day. So I wanted to share something that a colleague of ours in this community, Javid Sukera, recently wrote and posted on LinkedIn, because I felt it really reinforced the importance of both truth and reconciliation. He used the metaphor of the mirror and the lamp, where the mirror shows us the truth, including all the cracks and the flaws in ourselves and in society, and the lamp lights a way forward that is more hopeful. And he noted that sometimes we might lean too heavily on the way forward, saying that we might paint hopeful visions without enough reckoning with the truth, whereas other times we might lean too heavily on the truth and become overwhelmed by the weight of inequity, and that the real work is to learn how to hold both. So I thought today's talk by Dr. Orkin is an example of doing that. He will share some very provocative truths and a very interesting path forward, I think. And I also wanted to recognize that Indigenous communities have long practiced some of the care that is rooted in land, kinship, and reciprocity that we might hear about and reflect on today. So with that, I'll introduce Dr. Orkin. Aaron Orkin is an emergency and public health physician scientist and associate professor at the University of Toronto. He's an associate clinical professor and head of the Department of Hospital and Institutional Care at the Toronto Metropolitan University School of Medicine.
Sorry, can I give you this?
Sure.
It's on my use.
That'll help. I might just hold it for now. He's the co-chair of the Canadian Red Cross National Medical Advisory Committee, and as Ontario's first fellowship-trained clinical public health specialist, his practice and research focus on strategies to integrate clinical practice and population health, especially through programs that redistribute healthcare delivery and engage the general and lay public directly in the delivery of health services. Over 2 decades, he has worked with local, regional, and national organizations to deliver and evaluate care redistribution programs, reaching millions of Canadians. A quick housekeeping item. Please enter your questions throughout the lecture into Slido. We will have a slide with the QR code up, so you can grab that now and put the questions in, and we will review and respond to those after the talk. So with that, please join me in welcoming Aaron Orkin.
Thank you. Thank you for that incredible introduction, and very high bar to jump over. I really want to emphasize, just as we start, that just the idea that folks would turn up to listen to some of the geeky, esoteric fascinations that I have about health systems is a huge honor, and that even more people would join online is an enormous honor. And I also just want to say that in the culture that we have right now that is so brief, with such short X's or tweets and such brief videos that we all slide through, I want to congratulate TIER for maintaining the long form, in that it is an incredible honor and privilege to speak for a little bit more time, to share ideas in a longer format with you. But with that honor comes the recognition that all of our brains are changing through all of these technologies that we have, and it can be hard to pay attention for 40 minutes. And so what I want to emphasize is that I would sooner have a vibrant conversation with you than get through any of my slides. And so if you have an interesting question, or even better, something that you disagree with that I say, please put your hand up and let's talk about it, and I'll figure out how to get through my points. And let's go with that instead. So please engage. And I don't know what the mechanism is for engaging online, but maybe you can help me to know if somebody has a question online. Is there some mechanism for that?
Monitor and share.
Fabulous. Monitor and share. So I'm going to start with some, there was actually a slide before this. Nope. Let's try to go that way. There we go. So what are we talking about? We're talking about this concept that I call care redistribution, and the idea that everyone might be the solution to the health workforce crisis we have. And I hope that through this talk I might show you just how different the idea of everyone is to the predominant approaches that we see to the healthcare crisis right now. So here are my competing interests. This might seem an odd thing to say right at the top, but I'm a member of a regulated health profession. I make most of my money from the provincial government as a physician, billing OHIP. And I think you'll see that over the course of this talk, that could actually be seen as quite a bias, but a bias in the wrong way, in that being a member of a regulated health profession ought to bias me toward the belief that a service monopoly for regulated health professions is really the best way to ensure safety, effectiveness, and equity of health services. This might be the point where the first person stands up and disagrees with me, but I deeply believe that the foundational purpose of our regulated health professions is to say that we, the regulated professions, are the best way to achieve safety, effectiveness, and equity of health services. I hope that you'll see that my whole presentation upsets that interest. So perhaps my competing interest goes in the wrong way. I have received grants and travel related to the delivery of first aid from the Heart and Stroke Foundation, from the Canadian Red Cross, and the American Red Cross. And so I'm interested in studying people who aren't regulated health professionals and how they contribute to healthcare. So here's the plan for today. I hope to start by convincing you that there's a question worth asking, which is the solution to a shortage of professionals just more professionals? Next, we'll move on to an inquisitive history of ideas on the concept of non-professional workers. This has a long history. Okay, people have been caring for one another since the dawn of time, and there's therefore as much to be said about the tradition and history of non-professionals caring for one another as there is to say about the history of professionals caring for one another. I hope then to show you that although we can talk about that history and talk about the theory and the ideas that have been built around non-professional health providers, that I think we need better theory. I think that the theory that we have right now to characterize lay health workers and non-professional health workers is a little bit polycythemic. I'll get back to that concept in a bit, and move from the idea that we should be using a concept that I call care redistribution rather than the more dominant concept called task shifting. And then we'll close out by talking about what strategies we might use to enable care redistribution within our communities and society. So let's get started. Is the solution to a shortage of professionals just more professionals? I hope I don't need to convince you that we actually have a health workforce crisis. I'm going to spend very little time on that because if you're not there with me, we might not have a whole lot of solid ground to move on together. But this is just one graph from the federal government's report, Caring for Canadians, Canada's Future Health Workforce, which shows us that if we take, say, family physicians or RNs or practical nurses, that we're dealing with somewhere in the next 10 years between a best case scenario of like maybe 10,000 short in terms of headcount of workers and 35,000 short. And that's just some of these professions. I could take you through the document and there's more graphs and the story just gets more gloomy. Okay, I am a part of many programs that are reasonable attempts to fix this, like starting a new medical school at Toronto Metropolitan School of Medicine. But I will also confess that deep down my belief that we can fix this gap with more professionals like this, that if we just start enough medical schools and expand the number of positions in medical schools and nursing schools and OT schools, I just have this hunch that we can't fix this that way. That the health needs that this is intended to fix can't be fixed that way. And what I find depressing about this sort of a report is that if you then move into the recommendations, and I've just highlighted the title of those recommendations, like thinking about the health professional's role, education, training, and health workforce data, the employer role, health workforce projection modeling needs to be improved. We need to focus on rural and remote education, health professions education and training planning is in there. I see nothing that isn't about professional solutions to a professional problem, right? We really have a little bit of an issue around providing healthcare where we, as professionals, say, if all we have is a hammer, every problem looks like a nail. We just keep saying we need more of the same to solve a problem that is caused by a deficiency of the same. And so I'm left wondering, where is the recommendation that says move care between professionals more assertively? Or where is the recommendation that says reconsider whether all care even needs to be delivered by these sorts of professionals? Because that would really change the numbers that we need. And what's sad about that is that we actually have such a deep literature, such a deep practice, and I'll show you such a deep history on doing exactly that. So why is it that that major approach to delivering healthcare is just absent in our national strategy on delivering health services? Now, this problem is not just national. It's present very locally, too. Let's go the other way. Anybody seen this graphic before? Anybody applied for grants related to this graphic before? I have. I've been involved with some of you in applying for grants that are related to this graphic. This is Ontario's, I think right now, quite proud primary care plan about connecting every person in Ontario to primary care. And I won't go through the whole strategy just through the graphic, but graphics I find, just like abstracts or titles for paper, become really the only thing that people end up reading in the document. So it's really a powerful communication tool. And what we see here is this idea that you've got the person, their primary care system, which is composed of family physicians, nurse practitioners, nurses, allied health providers. You'll see that there is nothing in here between highly trained health professionals and the person and their family themselves. And I'll show you through the course of the history that I'll share that this very concept of primary care, going all the way back to Alma Ata, positioned the biggest possible bar in this graphic as having nothing to do with these people. Our foundational concept of primary care globally placed the biggest emphasis on a group of people who are not on this graphic at all. And then as you move out here, the specialty of the professionals just get more profound. You have more and more emphasis on health professionals, complex care, tertiary care. You have this very nebulous notion of community support workers, which in a very strange way are positioned farthest away from the home. There's these highly professional people between the community support workers who are weirdly next to the lab and not even close to the person. I think I've said enough about how I feel about this graphic. Okay, so I hope I've convinced you that A, we have a health workforce problem, or you were convinced before, and that B, there's like something mysterious going on in how we're thinking about it, at least federally and provincially, and that at least some of our dominant documents or some of our cultural anchor points, or since we're like in the region in Toronto of power around healthcare, that our powerhouses and thinkers of solving this problem in this sort of district are not really thinking about solutions to this that are not about professionals. So let's talk about that history. Has there been a history of non-professionalized health workers, and what does that history look like? All right. I am going to start at the French Revolution, and that is not because it's the only place to start. I really want to emphasize, especially since we started this talk with a reference to some of the interculturalism, understandings of colonial history that need to be worked into this, understandings of how strengths related to non-professional care might be rooted in non-dominant, non-colonial cultures. So the fact that I'm going to choose some examples that come from, say, the French Revolution are intended for two reasons. First, it's because it's a history that I'm familiar with and comfortable sharing. And second, because it might actually highlight that some of our beliefs that non-professional workers is a non-Western concept, it might upset some of that belief. I hope that I can show you through some of this history that it's actually also a very Western thing to think about non-professional workers and to really think about how that might work within political systems. And that might help us to see that this doesn't require massive cultural shifts, but actually might create an opportunity to say, this is something that's just part of global human history, not part of one culture or another. So why am I talking about the French Revolution and showing you gory things of a guillotine? You might not know that the guillotine is actually named after a physician. Guillotine was a doctor, so it's named after a person, Ignace Guillotine, who invented this device. A major thread in the French Revolution, along with the intention to do away with political aristocracy, was the idea of doing away with professional aristocracy as well. So through the course of the French Revolution, the very term médecin, doctor, was banned. The initial colleges, or the precursors to what we would now see as colleges, were dismantled. Many physicians, because they were seen as aligned with royalty, were beheaded on this very guillotine. And a new class of health workers was deliberately invented. These were called the officiers de santé, and that means health officers. They were initially intended as members of the French Revolutionary Guard, who were trained in basic healthcare, both preventative and curative, and positioned out in the community. So like community, we might see with community health workers now, there's an intention to position these health workers not within isolated ivory tower professional environments, but out within the community, serving community members within a very revolutionary philosophy. And the reason why I start in part with this revolution is I would like you to link this idea of lay workers with a revolutionary history. These approaches to healthcare seem to pop up not only because we have a crisis of service delivery, where we say there's a shortage, but also because we have a crisis of politics, where people say not only do we have a shortage, but maybe there's a political upheaval, which today we might call an equity issue. And there's differentials in access. So not only do we need more care, but we need to think about where that care is provided and how it's provided. And nowhere was that more real than in the course of the French Revolution, where that was so actively debated to the very point of beheadings. Okay, so the officiers de santé actually remained a structure within French society well into the 20th century. It evolved and continued to be professionalized, and that's the second main theme I want to share with you. There appears to be a tradition over the course of the development of lay health worker programs where it starts off very grassroots, starts off very lay, and then folks working in that field say, well, we're doing fantastic work. And it appears that the best way for us to get recognition and pay and appropriate remuneration and so forth for this work is for us to also become a profession. And so the officiers de santé slowly became a profession and were ultimately, into the 20th century, merged with French medical colleges. So started off lay, started off public, started off with a very anti-professional intent, and slowly professionalized over 250 years. Now this story also links with the history of the Red Cross. Okay, and I think that's quite important both for Canadians to understand, because there's a nice link here with Canadian or Canadiana and Canadian history. But anybody know who this guy is? Anybody heard of this guy? This is Henry Dunant. Okay, Henry Dunant was a Swiss businessman who was very much aware of the politics of the day, very interested in the place of states in military conflict, and very interested in volunteer health workers. And so this is just outside Castiglione in Italy, where the Battle of Solferino happened, which was the last battle of the Second Napoleonic Wars. This battle was a total bloodbath. Okay. Henry Dunant happened to be in the area actually looking for some of the aristocracy that was leading this war, and wrote a self-published pamphlet about his experiences there. That self-published pamphlet, it's like a little booklet, became the foundational sort of source document that ultimately created the Red Cross. That source document was about two things, one which is very well known and one which is lesser known. The first, which is very well known, is what we often think of when we think of the Red Cross. Dunant said, wouldn't it be wonderful if we had a neutral body that when there's a horrible bloodbath might show up and provide care regardless of the soldiers, well, regardless of which side the soldiers are on if they're injured. Regardless of which, wouldn't it be wonderful if we had people who said, when there's fighting, we care for the soldiers regardless of which side they're on. Most people know about that concept of neutrality in the Red Cross. But what was, I think, equally revolutionary that Dunant did is that when he showed up at Solferino, he organized that by engaging volunteers. He organized hundreds, mostly women and girls in the local community, who at that time, remember, the nursing profession had not yet been formed. The nursing profession is actually formed through the story of the Red Cross in many ways, and said, we're going to give you basic skills to care for soldiers and organize you as the teams to care for those soldiers, creating what at that stage was quite a revolutionary model of caregivers who were not in any professional role, were not associated with the military, had only a voluntary intent. That's the whole second half of his thesis, which gets a lot less attention in the Red Cross, but was a big part of how the Red Cross was formed. This idea of volunteers can change the world, not professionals. Now, what does this have to do with Canadiana? Oh, wrong way. That's another picture of Henry Dunant up there. But down here, okay, is this Canadian surgeon who happened to also be in the region. This is truly coincidence. He happened to also be in the region at the same time, met Henry Dunant, helped out with this. This guy's last name was Bethune, okay? He was Norman Bethune's grandfather. Norman Bethune being the guy who you might see a statue of him behind the medical school, the famous Canadian soldier who then ended up a household name in China during the Chinese Revolution. Norman Bethune absolutely venerated his grandfather. There is a very strong link between the beginning of the Red Cross and Norman Bethune's work that I'll get to in just a moment. But Dunant wrote, "Why have I told of all these scenes of pain and distress?" He wrote about this bloodbath. "And perhaps aroused painful emotions in my readers. Why have I lingered with seeming complacency over lamentable pictures, tracing their details with what may appear desperate fidelity? It's a natural question. Perhaps I might answer it by another." And here you have the formation of the Red Cross. "Would it not be possible in time of peace and quiet to form relief societies for the purpose of having care given to the wounded in wartime?" And that's what most people know right there, just that first part. But then there's the second part. "By zealous, devoted, and thoroughly qualified volunteers." Okay? He is not talking about teams of professionals or let's train thousands of military medics and give them a badge. He's saying volunteers. Might volunteers be the secret ingredient to this huge public health problem of that time, which is military casualty? So Bethune's son, or grandson, ends up really into what his grandpa was up to, okay? And ends up in the middle of the revolution in China and writes something just so similar. So he was a surgeon, and he writes, "The work I'm trying to do is to take peasants, boys, and young workers and make doctors out of them. None of my doctors have ever been to college or university, and none has ever been in a modern hospital. Most of them have never been in any hospital, much less a medical school. With this material, I must make doctors and nurses out of them, 6 months for nurses and 1 year for doctors." Okay? I think he's using the term doctor and nurse in a very loose sense here. What he's saying is that I want to take folks in order to change the health of this nation in the context of a revolution. Remember, there's the political element as well as the aspect of accessing care. And I want to position people who are not highly trained professionals to be the backbone of health services. And this is exactly what ends up being built as a real cornerstone of the revolution, okay, which is the Barefoot Doctors Program. Has anyone heard of the Barefoot Doctors Program, even loosely? Yeah, fantastic. And so what's interesting to know is that Bethune, and this may still be true, Bethune, many people believe, might well be the best known Canadian in history. And the reason for that is he's mentioned in the Little Red Book, and to this day is a household name across China. So 1.2 billion people, if you ask there who's Norman Bethune, will tell you. Most Canadians don't know who Norman Bethune is, but he may well be the best known Canadian in history. What came from that idea, that nugget of saying we should train the public, we should train people who are out in communities to deliver health services, was the Barefoot Doctors Program, which initially was a program offering basic, preventive, and curative care training to people who were agriculturalists. So this was not intended to be a profession all its own, in the same way that we might see with a, say, first aid provider on a mining team or on a construction team, where you say, you're still doing construction, but we're going to give you some training. These were agriculturalists who were still working as farmers, who were offered dedicated training in primary care to offer their community, and became the absolute backbone of the Chinese healthcare system throughout that revolution. The Barefoot Doctors program, again, also was alive and well into the end of the 20th century. And that program, in the same pathway as the Officier de Santé, slowly professionalized, offering more and more curative training, more and more advanced certification, and even pathways to enter regulated health professions for those people, until finally it was absorbed and closed into the professions. Okay, so it follows a very similar pathway. And we're talking about millions of workers here, all right? Not small numbers in small communities. So what effect does this have during that time? Because in 1975 or so, in the late 60s and early 70s, you have these experiences in places like China and the massive implementation and transformational implementation of primary care services, not through professionals, but through lay workers. You have the creation of our foundational documents of what is primary care. Okay, the very invention of primary care comes hand in hand with these kinds of programs. And so Alma Ata, which is the foundational document around primary care, comes straight out of the Chinese Barefoot Doctors program. And here's a document by Kenneth Newell, who is one of the physicians who wrote supporting documents to Alma Ata. And he writes about this concept of a primary healthcare worker. The common element is the use of a primary healthcare worker who does not fit into the expected description of a doctor or nurse. This person is frequently a villager, selected by the community. Like, there's all the key elements of how you would design these programs. Villager, not an outsider, selected not by the people who hold the money, but by the community, and trained locally for a period that can be short. An unpaid, or even an unpaid volunteer, or a person partially or totally supported by the village people in cash or in kind. So somebody who reports to the people, not to the professions, and with responsibilities for aspects of promotional, preventative, or curative health. Author after author describes the primary health worker as one of the keys to success, not only on the grounds of cheapness, but because he or she is accepted and can deal with many of the local problems better than anyone has done before, and because he or she is there. I love that they are there, not from away. It's not about pulling people who are from away into the communities that need them. It's about saying, we can teach healthcare to the people who are there. The primary healthcare worker is no butterfly flitting in or out, but is both present when wanted and still there to live with the results of his or her actions. So they're embedded. But here's the great part. You know how I talked about how in other parts of this revolutionary history that I share, that there's a tendency to move from totally lay, totally in the community, and then over decades or centuries to professionalize and ultimately get sucked into the professions. And we see that problem now. I'll get into that a bit. This foundational document that I'm so excited about also has little nuggets that show the problems. Because one of the other problems we've seen in lay professions is the tendency for that person to be very vulnerable. The professionals have a lot of power and can, especially when this person doesn't earn a lot of money, doesn't have a lot of traction within that community, can be very vulnerable. And Newell writes it right in here. You can also get rid of or replace him if you need to. You see? So like, I really want to emphasize that I don't think any of this is like a panacea, right? There's not a solution that I'm offering here that it's like, if you just do this, everything's going to be okay. And it's written right into this foundational document. Kenneth sees this as a good thing, right? And you can see within any system why this might also be important if there's real problems to be able to, well, replace him. But it can also be a tremendous source of vulnerability for lay workers. And it's right there in the foundational document. There are more contemporary examples too, and I want to share this one, especially if who watched The Pit? Anybody? Did you enjoy it? I enjoyed it. It felt a bit like my life. There was an episode in there about a patient who was having chest pain and was having a heart attack, who, although he had no formalized education, started talking basically medicalese to all of the doctors. You might remember that. And it was a reference to this program. It really is one of my favorites. This is the Freedom House Ambulance Service. Okay, in the region of Freedom House in Pittsburgh, like most of North America, before the creation of ambulance services, emergency medical response was delivered by police. You would just call the police and they would come and help you get to the hospital. For everybody, that meant you got pretty bad care, just not because police are unable, but just because it wasn't the focus of their care. But for people who were otherwise marginalized, especially black communities, that meant that when there were issues specific to those communities that distanced them from police, that not only would the police give bad care, but people wouldn't even call. Right? They say, I don't even want police involved here, which led to tremendous rates of what we are still dealing with in communities now, like overdose, problems related to injury, and so forth. And so not only would police provide bad service, but people wouldn't call for many entirely legitimate reasons. And a team of physicians at the hospital that is supposed to be shown in the pit decided, well, rather than teaching police or trying to create people who would serve as bridge workers and improve relationships between police and the community, which was also important, rather than doing that, why don't we find folks who live in the community and are trusted in the community and who cares what education they have, and let's teach them some first aid, and let's buy them an ambulance, and let's create the first proper ambulance service in America. So that concept didn't even exist. The first ambulance service in America, and really as far as we can tell in most of the Western world of its kind, was not just developed for the purpose of making sure people knew resuscitative skills and trauma skills and that they had the right skills. Remember, here's the hook. It was also revolutionary. The intention was not only to provide care where there's an access barrier, but to really disrupt the power relationships between a marginalized black community and the health system that they could only access through the police, who were among the people that made them feel so marginalized. Okay? So remember, lay care seems to be linked between access and revolution all the time. Okay? I don't want to suggest that this was the only such program. This was like 1968. 1965 was when the Orthodox Jewish community in Brooklyn started its Hatzalah service, okay, which was also an ambulance service. And their reason was that for reasons related to their religious needs, they couldn't get health care that could transport them appropriately or respond appropriately based on their cultural needs. And this is still a massive service in across New York City. There's over 1,000 volunteers in Toronto's Hatzalah service, many associated with the University of Toronto. You might sometimes see their ambulances around. And so this concept of creating culturally appropriate ambulance services links both issues around access and local issues around cultural need. Very different cultural needs in these two communities, but you can see the link that each community is solving its cultural need by training local volunteers rather than trying to get the mainstream professions to suit their needs. So we move this forward a little bit further, and all of a sudden in the 90s, we see an explosion of literature, of science, of conferences from the World Health Organization starting to talk about this concept, and they use the word task shifting. This explodes in the context of the 1990s HIV crisis and the idea that if we just had enough community health workers, mainly in North Africa, Central Africa, and Southeast Asia, that we could control the HIV crisis. That the major need for community health workers is to fill a gap in access to antiretrovirals and preventive care for HIV. And that's where this concept of task shifting takes off. And they define it like this. They say task shifting involves the rational, we're going to hold on to the word rational, redistribution of tasks among health workforce teams. Specific tasks are moved, where appropriate, from highly qualified health workers to health workers with shorter training and fewer qualifications in order to make more efficient use of the available human resources for health. I hope that you can see right here that the access and the idea of delivering a service like maybe resuscitative care for the Freedom House ambulance service is there. We got to deliver a task. But the revolutionary element is like gone. It's like it's been neutered, right? It's just about delivering tasks to the people. Healthcare's tasks, we got to just do the thing, right? The revolutionary element is gone. And I hope I can, over the course of the rest of the talk, convince you that keeping these two things together is key to us achieving the goal. And task shifting just takes off in the literature. It just like completely takes off. This is a bibliometric analysis of the term task shifting and related terms like task sharing. And you can see it gets invented around here. And the literature, the papers on it just absolutely explode. It becomes the dominant terminology, the dominant theory. And I'd say that in having plowed through many of these papers, it follows that the revolutionary content gets pretty weak. And the attention to the tasks gets pretty focused and solidified. But there's beautiful projects underway in spite of that, and I want to share some of these projects. This is my favorite paper of all time. I wish you would all read it. It changed my life. I have an academic crush on Abe Bang. He's the most incredible person, and his papers are just phenomenal. In this incredibly impoverished region of Gadchiroli, India, I don't want to assume that I know much more than this paper about this place. Does anybody have family or know people in this region of India, or has anyone been to this region of India? No? Okay, I'd like to go there one day. Join me. Mortality among children under 5, which was predominantly driven by infectious disease, especially gastrointestinal and respiratory disease, was absolutely extraordinary. We're talking about rates of 40.7 per 1,000 kids under 5 dying, okay? There's incredibly limited numbers of professional health workers, and Bang and it's actually Abe Bang and Rani Bang, it's a couple. How beautiful is that? They study this together. Decided that they needed to train people to care for children, but access to nurses, doctors, et cetera, non-existent. And then when they investigated this further, they discovered that the real challenge was that they wanted to teach people to count breath rates so that they could say, this child is breathing too fast, this child needs to get to a hospital. But they discovered that most of the people they wanted to train could not count over 10. So I want you to just internalize that. The level of basic sort of mathematical or schooling knowledge, dealing with people adults who can't count over 10. And he invented this object. This is a true invention, where you flip it over, and what they were told is each time the baby breathes, move a bead. And if you move all the beads before you run out of sand, that kid needs to go to the hospital. That's all they did. That was the intervention. And they distributed thousands of these, and they taught people to use it. And they reduced absolute all-cause mortality, okay, by 12%. These numbers, you just don't see this in health research. Absolute all-cause mortality drops of 12% by distributing this to lay people who can't count over 10. Okay? Is it a task that's shifted? Yes. Is it revolutionary? I hope you agree it is. But you just don't see outcomes like this in anything else. Similarly, you have things related to mental health. This is a program that was started in Zimbabwe, called the Friendship Bench program, where there was identified in that region of Zimbabwe, there were 2 psychiatrists to serve the entire region. One of the psychiatrists basically trained grandmothers with basic mental health counseling, screening, and referral tools with an absolutely staggering effect on depression symptoms. And all they were given was a bench with a little sign and some basic training, and told to tell people, if you want to come talk to a grandmother about how you're feeling, just sit down on the bench. Okay? Intentionally revolutionary, you'll see that it is. Tasks shifted, absolutely. Now you have grandmothers trained to provide mental health care. I don't see any reason why we shouldn't see benches like this in Toronto, but I hope you'll agree that the model's inspiring. I've studied this effect on emergency care more widely because I'm an emergency physician. It turns out that emergency care after the most basic hygiene interventions are the single most effective way to save lives globally. On conditions ranging from cardiac arrest to malnutrition, opioid overdose, snakebite is actually a major cause of morbidity and mortality globally, that training lay people to deliver interventions, deliver first aid, is the most effective way of getting this care to people. It's not about building paramedic programs or hospitals. The general public is the way to do this. Here in Toronto during the pandemic, we trained 27 undergraduate students at U of T to deliver vaccines. Here's what I want to tell you about the program. What was amazing about these vaccine clinics was that nothing was amazing about these vaccine clinics. There were students trained to give vaccines. You came, you got your vaccine. Nobody got a needle in their eye. Nobody grew gills. Nobody turned green. It was like completely mundane. Okay. Meanwhile, we were paying doctors and nurses hundreds of dollars an hour and bemoaning the fact that we didn't have enough of them to give vaccines when the lay public could have been taught in minutes to do it. And then nothing weird happened when we did. Okay. I'll skip over that. Similar programs have happened over the course of my career to respond to opioid overdose. If you go take a first aid course from the Heart and Stroke Foundation or the Canadian Red Cross, they will teach you how to use a naloxone kit, how to recognize overdose, how to respond to overdose. When I started in my training, the idea of giving the general public naloxone was seen as insane. You would have, as an emergency physician, I would have been taught that you will have catastrophes all over the place if you do that. But this takes a deliberate process of change and I think an intentional, a revolutionary intent to produce this kind of change. Okay, and this is now in every first aid manual. Okay, if you have a middle school child who's going to take first aid training, they will learn how to respond to overdose. Meanwhile, you have adjacent programs that are describing themselves quite differently, but I think incorporate similar themes. So this is a report from the Health Common Solutions Lab, which I think is still associated with Sinai Health, talking about this concept called community ambassadors. And has anybody worked with or on a community ambassador program of some kind? Yeah. Are you a community ambassador?
Yes, before, but now I moved to the other place. Yeah.
Fabulous. Okay, so I'm speaking to a true expert, but I want to capture for you the logic model that's imposed here. So there's an if, then, and a solution. And the logic model is, if the care system is going to close long-standing gaps in health outcomes, it must confront the challenge of effectively reaching people who have had the least access to social determinants of health. So there's an idea that access to care is the problem. To do this, new and flexible tactics, strategies, models, and roles are required that center the needs of diverse people, not just the typical or easiest to reach person. And then it says community ambassadors, and this is the part that I find interesting, but for reflection. Community ambassadors are non-clinical, hyper-local roles that are filled by trusted members of the community. They work with community members to creatively remove or reduce barriers they face when accessing and navigating their social determinants of health, acting as a bridge to the healthcare system, which is so different to even if we go back to guillotine and the idea of the officier de santé. Embedded in this logic is the idea that you don't train health ambassadors to deliver healthcare. You just train them to kind of bring people to the healthcare, right? And I see this, well, I'll leave it to you for reflection, which is this a sufficient model? Is this giving health ambassadors or the people who become health ambassadors the credit they deserve? Why wouldn't we just teach them to deliver the service in the way that Kenneth Newell might describe without that last part? And say, you can actually do this care rather than just bringing people to the care. How does that happen? Why do we choose this model? I'll leave that to you for reflection. In Jersey, UK, and this has been commented on in Canada, anybody know about the National Institute on Aging in Canada? Anyone affiliated somehow? Fantastic group. They comment on a program in Jersey, UK called Call and Check, where postal workers, and maybe it's an opportune time to talk about this because the postal system's in a bit of a crisis. Postal workers are trained to provide basic check-ins with the elderly community that they encounter on their route. Postal workers are incredible because they're out and about, they're in the community. And weirdly second mostly to healthcare workers, if you ask the public about who they trust, they actually really trust their postal worker. And so this is an incredible program creating connection. Where the postal worker is actually given some real health intervention training. And the National Institute on Aging has asked, why couldn't we implement this in Canada? I think we could. Okay, so that's a form of task sharing. So I hope I've convinced you that small changes in health knowledge and skills among large numbers of lay professional workers can have a seismic impact on health and health equity. And I'd posit that this impact and that this kind of impact might be very hard to achieve with scarce professionals. Just having more scarce professionals is not likely to achieve the kind of impact you achieve here. Using my overdose prevention, naloxone distribution model, there is no number of doctors and paramedics that I could train to respond to overdose that would have the same effect as training the general public in a first aid course to respond to overdose. And there is no reason why we can't think of other problems in the same way, ranging from vaccination to mental health and everything in between, that we say, why are we thinking that professionals are the solution rather than deliberately deprofessionalizing? So let's talk a little bit about theory and try to see whether we can move from this task shifting concept to something that might propel the change that I'm excited about. So I'm going to try to convince you that the existing kind of common examples of lay workers that we see right now, they're going off in like weird, incompatible theoretical dimensions that don't really help us to bring this all together and do something useful. So the first one might be these health ambassadors, where we say that ambassadors are a bridge between the clinical and the community. The ambassador word is very valuable there. Ambassadors tend to work through diplomacy. They're first about bridging cultures. They're not about changing cultures, or at least, most diplomats wouldn't say, I'm here to change the culture. They'd say, I'm here to work across cultures. And so this is a concept that I think kind of moves in one direction that doesn't always fit with these others. Then there's these peer worker programs. Okay, the logic behind many of the peer worker programs I've been involved in is that people who use drugs or sex workers as examples are harmed or traumatized by care from health professionals who don't understand or meet their needs. And then the idea is that if we empower peer workers to take control of their care and to enable people to control their care. But I've noticed that peer workers, in a way that's so different to the Barefoot Doctors program or to Newell's vision, peer workers are seldom positioned to say, you know what, you deliver the care. You be the provider rather than bridging between these worlds. So there's still this bridge concept. What next? Then there's this mothers and grandmothers concept, okay, which is a little less revolutionary than this peer workers concept, but it's this idea that people with existing caring relationships, people who deeply care for the people around them, have a special aptitude and willingness to deliver appropriate and empathic care. And the logic is, if you give them more skills, like that bench program, they can add clinically effective caring to their deep personal caring, and health will improve. But what I find is that this model makes it very unclear how we scale that. People tend to be quite uncomfortable with the idea that we're either going to exploit a lot of grandmothers by asking them to volunteer all the time, or that we're going to professionalize the role of grandmothering by saying that it's appropriate to push you into a clinical context. So this is uncomfortable for me as a theoretical solution. Then there's the sort of first aid paradigm, which is very basic, that emergencies need care before anyone can show up on time, right? I need something now, and you are here, and it'll take a while for 911 to get here, so maybe we should teach you to do something. But what I find this logic overlooks is a strong history of first aid, like I showed you with the ambulance services, that says it's not just about fast care. First aid is locked into this idea that it's just about speed. But the history of paramedicine and first aid shows us that it's also about changing power relationships, that it's actually about empowering people in a way that we see much more up here. So first aid doesn't seem to be a great framework either. And then there's community health workers, like we've seen internationally. Community health worker programs in Canada are woefully underdeveloped. And the idea that doctors, nurses, and midwives are just too expensive. And so we need to train some lower cadre that can be trained really quickly to do this job. But we have this recurrent problem that they don't seem to be empowered to drive the health system. They seem often to be subservient, especially in environments where there are so many professionals. So all of these things are like cousins that have never met. They go off in different directions, and they have so much to share and so much shared history, but they don't even know about it. And that gets in the way of program growth, gets in the way of knowledge sharing, and they don't recognize their braided histories and how much they have to share. And I think it's because they don't know that they have a shared last name. You know what I mean? They don't know that they all came from the same village. And I'd like to find a way to introduce them to each other. So I'm going to skip these slides because I think that there are three reasons, at least three reasons, why task shifting is like a completely pancytopenic theory for this. It's deficient, it's anemic. The first is that it's centralized. I'm going to just skip these and tell you the three reasons. It's centralized, okay, that task shifting without use of the word rational believes that the World Health Organization and national entities are going to decide to shift tasks rather than taking a grassroots approach, okay? The second reason is that it's preoccupied with tasks. I do not want to work in a health system where we really believe that the sum total of healthcare is a series of tasks, that we have to check all the boxes and then we've delivered good healthcare. I'd like to believe in a philosophy of caring. And the third is that task shifting, as I showed you at the beginning, is politically naive. It suggests that we don't have a political problem, we just have a task delivery problem. That equity has nothing to do with politics, it just has to do with delivering the right tasks to the right people at the right time, which I don't think many of us believe. I propose what I think is a more cohesive concept, which I call care redistribution. And I think that care redistribution, we could define it as a phenomenon that occurs when communities deliberately reallocate or reassign caring practices, functions, and relationships with a specific goal to enhance care, to improve health, and to redress inequities, okay? When we're doing those things and we're doing it deliberately, we're engaged in care redistribution. I like this term redistribution also because for those of you who have links to theories of justice, theories of economics, the word redistribution is deep. It's a deep well. It's a concept that's well developed with this idea that you can end up with fairer societies, more inclusive societies, when we treat things like justice and finances as a resource that can be redistributed. When we think about health as something that can be redistributed, that is not given access to some people, given more to others, and something that we can deliberately move around the map, I think we're deeply empowered to do something good. So, what strategies can we use to enable care redistribution? I'm going to go through 4. The first is we need to seek opportunities where redistribution can work. And I've done some work to try to develop a framework, which I can share with you, on how do I know when I've got a situation that's suitable for care redistribution. I won't go through all of it, but certain sort of catch bits are the idea that maybe part of the care can be protocolized. Maybe there's part of it that is well suited for algorithmic delivery. Maybe there's resources for scale up, that we say we need to be delivering more of this and we know we've got a pot of funding for it, and then we can stop and say, but why are we spending it on more doctors? Maybe we should spend it on everyone instead. Or there's new cadres of workers who are willing to be trained to deliver this. So I would never be able to start a lay vaccination program if there weren't actually students who are like, cool, I'm in, right? Are there people out there who are willing to do this? And you can move through this and say, hey, we've got an opportunity for care redistribution there, okay? The second strategy I'd say is don't just shift tasks, redistribute care. And I've put this on here to show attention. Have we got any pharmacists in the room? That's too bad, because I feel like there's a war going on right now between the OMA and the Ontario College of Pharmacists about like all these things that pharmacists can do in other parts of the country. We need to move Ontario in one way, and then we've got the OMA saying we are working to protect the practice of medicine against scope of practice encroachment that might threaten patient safety, as though like people are going to grow gills and have needles in their eyes if doctors don't do everything. I think that this whole debate is wrong. It's not that I think one team is right or one team is wrong. I think that the debate is wrong, because I think that it's still professionals fighting about who does most of this stuff in a space that is still so inequitable that if we were really talking about redistribution rather than who gets to do what task, we would end up with different kinds of solutions. This is fighting about which task people get to do, not fighting about how to redistribute care to the public. The next one is to invent new roles. We need to be bold enough to like add a line down here. So like this isn't on the map, on the original one. We need to create new primary care paraprofessionals of some kind, okay? We need to go back to Kenneth Newell and we need to go to the folks who are developing this and say, like, have you even read what the primary care foundational documents were about that you're saying are so important? They say that you need a different kind of person who doesn't even exist in Ontario. Invent that person, empower that person. And we need to have the bravery to invent roles. And then finally, we need to insist that scarce professionals, people who have jobs like me, are properly trained and rewarded for doing redistribution. There are very well-developed policies from the college that I work with on how I can enable other people to do parts of what I do by training them, by overseeing them, by delegating them. There are legal structures for this. Most of the physicians that I work with have no idea that they can do this. But even worse, I believe that part of the reason why they have no idea that they can do this is, I'll confess, there's no way to get paid for doing this, okay? I can get paid a nominal amount for giving somebody a vaccine, but if I put together a team of people and give thousands of vaccines, I simply can't get paid for it. And I believe that that's the same across numerous professions. And so if you want to position professionals to be enablers of this, there needs to be a way to be a professional while doing redistributive work. So I hope I can finish with a concluding provocation. There's a whole other reason for caring about this right now, which is, I think, political to our day. In Canada, there's 97,000 physicians, roughly, in 2023. In roughly the same time, there were 350,000 PSWs. The highly, and I think PSWs are a nice example of a paraprofession being grown from a seed. It's huge compared to the number of doctors, okay? But the kind of attention and the kind of credibility that PSWs get in comparison to physicians is minute. We are seeing right now a tremendous erosion of public trust in expertise, in highly trained experts, and in the structures that make that expertise. One of those is universities. The other is professional colleges. And as I said to you, in the surveys done in the UK, after doctors, nurses, and so forth being most trusted came postal workers. I think we're in the middle of a period where health professionals, they're going to start dropping because trust in the universities and in the institutions that create those professionals is literally evaporating under us. Michael Roth is the president of Wesleyan University, and he said colleges and universities should do a much better job of contributing to civic renewal and not just gatekeeping or filtering, which is not something that will engender respect or support from fellow citizens. More colleges and universities should define themselves by how many people they positively affect rather than how many people they reject. We should celebrate the institutions that positively impact the most people. We need to be restructuring our professional roles in the same way that Roth is envisioning restructuring universities in our society. If we are not deliberate about empowering the PSWs, I believe that trust in the scarce professionals will soon evaporate, and I hope we don't end up in the same sort of circumstance that led that first example I gave you with guillotine and the destruction of the professions. So I think that this is an existential crisis for the health professions. I hope I have convinced you that there is a solution to shortage of professionals that's not just more professionals. I hope I've shared with you some tidbits of an interesting history around professional health workers and a way of seeing that history. I hope I've convinced you that we can move from something that's a little bit anemic, called task shifting, to something more inspiring, called care redistribution. And I hope you've seen some glimmers of strategies into how we might implement this. Thank you.
Thank you so much, Aaron. I'm getting texts from colleagues saying that their minds are blown. So thank you very much for sharing this with us. For the folks online, there was mostly some resonance and comments, so maybe we won't take any questions from online, and we'll let people move on to their next thing. For anyone who can stay a minute, can you stay a minute? Maybe we can have a little bit of discussion here, and if you have to leave, of course, you may do so. Please, before you sign off online, fill out the evaluation, and you can add some of your thoughts and questions and reflections there. Thank you so much for joining. And yeah, to the room. Oh. No, it was
Still, I guess, just
Maria.
Oh, thank you.
You were first. I'm going on a first come, first served basis.
So thank you. I really enjoyed the talk. I guess it's two questions, and I'm trying to debate if they're actually connected or if I'm just rambling at you. The first is that one of the things that struck me in the way that you're framing the argument is that you cast the professions in a very static way.
Mm-hmm.
And the professions are also changing, and expertise is changing, and how we define expertise is changing. So I'm wondering about how you think about that in relation to the work and the strategies that you're proposing. And then the second question, which is probably unrelated, so it's not fair to ask you both at once, but is this idea of, is there a danger that in a care redistribution model, you create a hierarchy of care as well? And so the things that are simpler or algorithmic or what we would call procedural become the purview of certain groups, but the more complex, dynamic things that are less amenable to algorithmic or routinized care still remain with the professions, and what's the danger of that type of stratification?
I'm sure we'll find a way to link those. But I mean, my whole practice is about finding disjointed ideas and seeing whether I can make loose associations.
I'm already linking it.
So I'm good with that. Are the professions changing? Absolutely. When I described that example of, I really was trained in a world where the idea of giving the general public Narcan kits would be seen as something that would make the sky fall. That would be seen as deeply unprofessional for me to continue to hold that view. It's a standard of care to distribute naloxone to the general public. And so the profession changes in that journey too. They take on different knowledge, they take on different positions within political environments. So that's absolutely true. I think what I'm trying to move past that is present and I think a bit static in health professions right now is the bickering that I tried to demonstrate between the OMA and the College of Pharmacists, or the Ontario Pharmacists Association, which is of a certain style. And I don't see much of that changing right now, or I haven't been part of that sort of a change where we say, rather than bickering about the boundaries between our profession, can we all see that we are so far on one professional end, and there's so much work to be done outside of that? I see, frankly, very little evidence that shifting between those professions produces the massive care that we need. There's no amount of having pharmacists treat shingles that's going to deal with the 35,000 doctor shortage that we have. It's just not the scale of solution that we need. And that's the kind of change that I'm trying to go for, where it would no longer matter whether we're talking about doctors or pharmacists or nurses, that we're changing much more. Am I worried about the stratification of care? More so when we use frameworks like task shifting, because then it's all about tasks and algorithmic approaches and isn't about transitioning who is a primary contact person for the depth of caring that I think you're talking about. That I think we could really start to move where and how people access caring relationships, which we know is not limited to health professionals and which I think is really getting eroded among health professionals. I don't think we have strong evidence that complexities like team-based care result in the preservation of the relationships that make primary care so powerful. And I don't think we have much investigation on that. We assume that when we go to team-based care that people still have the same relationships. I actually think that we might be able to move where and how people access the deep caring that they're looking for, which is not accessible when we have such a shortage of professionals, to people who really do care about them, and then have the professionals involved in work that is much more technical. And I see many professionals who already want that, who would say, I'm much more comfortable. I have colleagues who are in surgical fields who say, I would be entirely comfortable to be more in an operating technical role and have more colleagues who are engaged on the more, and we don't seem to enable that. So there's a both there, and maybe there's a link between your questions. Yeah.
Thank you. I'm really glad you had the long form. That was really,
Thank you.
Interesting. I share your worry about the emphasis around task shifting, and I wonder if I'm seeing it escalating because there's so much more happening in terms of datification, digitization that's got very linear, very rational, very logics of efficiency, big money, big power.
Mm-hmm.
It seems to be pushing us more and more towards all our solutions are going to be in process engineering, identifying tasks and redistributing them.
Mm-hmm.
And I'm wondering what you're potentially seeing around all of the promises around technology to solve some of these problems.
Yeah, if I'd shown you that bibliometric graph, there's a whole other study on the use of task shifting to non-human actors. Mm-hmm. So the term is now being used in structures like task shifting to AI, or task shifting to other technologies, or task shifting into other forms of robotics. And that's part of the reason why I'm like, okay, they can have it. Like, give them the term task shifting. I'm focused on care redistribution. The robots can deal with tasks. Because I think that maybe in a paradoxical way, the need and role for caring relationships is only increased as we figure out how to have robots doing the tasks. And I actually don't object all that much to, like, I'm sure there was somebody who would have told me generations ago that something very human is lost when people take their blood pressure on a blood pressure machine at the pharmacy, rather than having a touch of somebody with a stethoscope who does it doing a manual technique and makes eye contact with the person. And I'm okay with people getting their blood pressure on a robotic cuff. And I wouldn't object to the development of other technologies that could give a healthy, normal person a vaccine with a machine and no human involved. I wouldn't object to it. And so it's actually about enabling those things, not being afraid of them, while putting real energy into the things that are deeply human and saying we're going to have to figure out how to have caring relationships. And as I say that, I realize that there's a big gray area because we have lots of work on mental health counseling using AI and people achieving and getting some of the caring relationships they need from non-human actors. So it's part of the field, but I see investment in theory that's focused on caring as more valuable because of that problem, not less.
No, but I have a little tiny microphone, but I don't know if it's useful.
They're still there? Oh, okay.
Oh,
So
nice.
then, yes, please use the mic.
Thank you for that wonderful presentation. So I am visiting from Ethiopia. Well, as you know, Ethiopia does not have a lot of physicians and nurses. So I was trying to compare some of the things you're speaking about today about the Canadian health system and how it's developed and what you aspire to be, and to the conversations that we are currently having in Ethiopia. So I don't know if you know, but we have a program called Health Extension Workers Program that is started in the early 2000s. It's mainly relates to some of your recommendations of using lay workers who are rooted in the community to go to do house-to-house visits and do some of the work. Their work was initially focused on maternal and child health, because that was the biggest problem that we had about maternal and child mortality. But then eventually it grew into screening for NCDs and providing emergency care and things like that. And this community health workers were mainly women who have only had high school education, and they had small trainings, and it's a very effective program. But now, because we have done it for many years, we have used it for many years, we have also seen that it has its own problems. One is that the people who are going home to home in very difficult places, they're growing up, right? They're adding more years, so their priorities have changed. So they don't actually necessarily want to continue that kind of work as they continue to have their own families and things like that. And also, they also have their own aspirations of career growth, right? So they want to develop themselves in that area. And there is also issues of incentives. So they want their incentives to grow. They need to have more.
They want to
money.
professionalize.
Yeah, they want to professionalize. So it's so now we're on the, they're being given this advanced trainings every couple of years.
Mm-hmm.
And there's now a level 1 healthcare worker, and there's a level 4 health extension worker.
And soon there'll be a college. And
yes, so they now are asking to be nurses, right?
Yep.
And they actually introduce themselves to the community as nurses. And there's similar conversations around mental health care, around different healthcare issues, of also issues of international recognition of those services, right?
Yep.
So these people are not going to be recognized elsewhere. They cannot provide those certificates for any accreditation elsewhere. So how do you see that as you go on applying this kind of interventions. And also, just a slight clarity, there is a concept of task sharing now
Correct.
that's also coming
Yep.
up in the WHO literature. So how do you compare it to the care distribution, redistribution that you mentioned?
So I'll answer the first part first about how do I make sense of these community health worker programs that are massive in Ethiopia and massive globally, and virtually absent in Canada. There's a couple of ways I make sense of it. The one is that that observation is true. If we had a real interest in creating community primary health workers, the Ontario infographic that I showed you would have it on there. I just can't fathom how it would, if it was really an intent, that it wouldn't be on there. And so we are not doing in Canada something that is exactly analogous to what folks in other parts of the world see as absolutely central to the success of their primary care system, and that links with a whole history going through to the Chinese Barefoot Doctors program and otherwise with the whole concept of primary care. So somehow Canada is obsessed with primary care and has missed a core feature of primary care. That observation is true. There are a couple of reasons for it. I think one is that maybe we just missed the boat. The other is that Canadians have, and I think Ontario, has a deep aversion to the implementation of programs that globally are seen as associated with lower resource environments. That they, even if they do the same thing, they don't want it to call it the same thing because Canada doesn't want to see itself as having resource limitations. And that's something for over there where people don't have a lot of money, and here we do something different. I think that's insane. And it results in not learning from the rest of the world. But I think that is part of why the word community health worker hasn't found its place in Canada. So that's the second piece. And I have one more, and it's deficient, but there's probably 7 more pieces, but here's the one more I'll share, is that just because I can't see a perfect example, and just because we're not doing exactly the same thing with the same name, doesn't mean we're not doing things that are kind of similar. So some of the peer worker programs and peer ambassador programs that I described have elements that are similar with that, titled under a different name, even though there are some differences. And then there's the massive presence of PSWs in Canada, right? Which you could just like take a deep breath, change a couple of little things and say, let's call them community health workers. But they're focused mainly on older adults, which unlike in folks like Ethiopia, where the shape of the demographic curve is different, we'd say that the largest public health need in Canada is older adults, unlike say, reaching children or maternal child health or stuff like that. We'd say the biggest demographic need is older adults. And so the creation of PSWs as a cadre that cares for those, in many ways is the same thing, just responding to a different demographic curve. And so we are kind of doing the same thing with different priorities given the demographic curve and a different title. But and some of the challenges go in the same direction. PSWs want to professionalize, they want to have different levels of training, et cetera, et cetera, et cetera. I'm interested in whether we can find a way out of that we could we find a future where we can see the value of paraprofessionals and non-professionals so that we can create these groups without always going down a pathway to professionalization, where we see that like the promised land is always professionalization, because it's not. I don't think that that is a good promised land. And then your second question was about task sharing. Yes, it was very quick when task shifting was created that people said, no, these are about teams, these are about groups, we don't like the term, let's change to task sharing. To be perfectly frank, I see it as a meaningful intent that we're like, yes, we're talking about teams, and you can't shift something unless 2 people are involved, and it's got to be consensual, and so there's a sharing, not a shifting. But it's all the same thing. We're still not talking about a fundamentally different view of, like even the word tasks I don't think is great, and it eliminates the word care, and the sharing still gets rid of the idea that we have a political intent, not just a who does the job intent, because just having a team do it rather than one person do it doesn't attend to the politics. And the word redistribution is very deep in justice and economics, and I think should be used in health. That we're aiming to say these people need health redistributed to them, and we're going to put people in a job to do that.